Hi, and welcome to the 2021 Flex Program Virtual Reverse Site Visit. We're so pleased to have you join us for this event. My name is Tracy Morton. I'm the Director of Population Health at the National Rural Health Resource Center, and I'm the Program Manager for the Technical Assistance and Services Center, or TASC. TASC is your federally funded technical assistance center that supports the 45 state Flex programs, as well as the 1,300 critical access hospitals that they serve. We're in our 23rd year at the National Rural Health Resource Center, is serving as the TASC program through funding through the Federal Office of Rural Health Policy, and we're really pleased to be in that role. My role here this afternoon, is to first orient you into the session and then introduce you to our speakers. The theme for this year's event is Rural Resilience for Healthier Communities. We hope you had the opportunity last week to participate in the resiliency workshop that was supported by TASC. And we're looking forward to delving deeper into rural resiliency and fostering health throughout the Reverse Site Visit. We hope you leave the event after Thursday with new best practices and lessons learned that you've identified to implement in your Flex program and with your rural communities. We also hope that through the Reverse Site Visit, you can describe health equity and leadership activities that are relevant to your organization, to your program, and to you. We wish we were together in person. Hopefully next year we can, as I know that there's participants that joined their Flex program shortly before the pandemic, some even in 2019, or during the pandemic, that we haven't had the opportunity yet to meet in person. And we really look forward to that day. But through all of this, we've remained resilient, and we're so pleased to be joining you virtually from our homes or our offices for this special event to provide education and networking to the state Flex programs. I'd like to extend a very special thank you to the Federal Office of Rural Health Policy for funding and supporting this event, and to the volunteers and the planning committee who contributed their time and their creativity to make this event a success. The attendee hub you first access this first session today will be our landing place to access the links for all the sessions, the participant list, our networking sessions, and for downloaded content. The networking sessions will be held roughly kind of over the lunch hour, and there are virtual networking opportunities for the state Flex programs to just have a casual conversation on the set topic. We'll tell you more about that later on, but we really hope you take that opportunity up. All the plenary and breakout sessions are being recorded so that you can access them later on. If you should run into any technical difficulties, on the right side of the screen, there's a phone number and email address that will drop into the chat that you can use to help with that situation. You might want to write these down for future reference, but I'll say them out loud as well. The phone number is 877-563-0031, and the email address is nrhrcsupport@cvent.com. The participant microphones in the plenary sessions like this are all muted. We do, however, really encourage your questions and interaction with the speakers. If you have any questions during this session, you may utilize the chat box feature within the media player, and the TASC team will be monitoring that during the presentation to either answer your questions or communicate them to the speakers. Now, I'd like to introduce you to Tori Leach, the Medicare Rural Hospital Flexibility or Flex Program Coordinator with the Health Resources and Services Administration, Federal Office of Rural Health Policy. Tori, I'll hand things over to you.
Hi, thanks so much, Tracy. I am so excited to be with all of you at our second annual virtual Flex Reverse Site Visit. I wish, along with everyone else, that we were all together, and hopefully next year that will be a real possibility. So I'm here to welcome you today with my fellow Flex program officers, and we will go over some of the ways that we have gone through this past year, what we are looking forward to this year, and what is coming up in the future. So just to give a quick overview of what we'll cover today, I'll go over the hospital state division staff. We've had a very large number of new staff join us, and I wanted to give you a quick name introduction to each of those individuals. I'll then cover where we were, where we are, and where we're going. And we'll have the opportunity to hear from each of your FORHP Flex project officers. So here is our latest outline of the hospital state division staff. Of course, we have Christy Martinson, who is our division director, and Rachel Biscotto, who is our deputy. On the Flex team, you have myself as your program coordinator, Natalia Vargas, who is your MBQuip coordinator, Laura Seifert, who manages our financial and operational section, along with the Flex monitoring team cooperative agreement, and Talia Chappell, who focuses on our EMS efforts. On the State Office of Rural Health Program, we have our new program coordinator, Sarah Diangwi. She also oversees the NOSOR cooperative agreement. Michael Redmond is our now veteran SOAR project officer. He oversees the Rural Veterans Health Access Program as well. Suzanne Snyder is one of our newest members in the SOAR program. She also helps out with the Delta program that supports our hospitals in the Delta region. For the Small Hospital Improvement Program, we have our leader, Salamatsu Soleil-Berry, who is the program coordinator and also oversees the Vulnerable Rural Hospital Assistance Program. Janine Myers is our veteran SHIP project officer. She also oversees our newest program for the Rural Providers Transitions Project. Our newest HSD member is Jason Legier. He joined just yesterday. We are so excited to add this third position to the SHIP project officer team. He will also help oversee our new Delta Workforce program. If you don't know who your project officer is, there is a helpful link on the bottom of the slide that leads you to a map where you can click on your state and find out exactly who your Flex, SOAR, and SHIP project officers are. So this time last year, I was introducing you all to our brand new Flex project officer team. I was the new coordinator. Natalia was our veteran team member, and we had just brought on Laura and Talia. For program year one, we had the baseline measures for PIMS. So when we transitioned over to the new cooperative agreements, we had new PIMS measures. So year one was our baseline, and we will only improve from there. We also introduced the new end-of-year reports that gear towards capturing the full Flex program year. The Flex Project Officer team introduced logic models for each of the program areas that we hope you're finding useful in developing your future work plans. And we also recognize the impacts of COVID-19 on the Flex program. Many of you were unable to complete major projects, had delays with contractors, or delays working with your hospitals because there was just so much else that you had to do. We fully understand that and hope to support you in the future as you are still feeling the impacts of the COVID-19 pandemic, as it is not yet ended. Now I'd like to turn things over to your MB-QIP program coordinator, Natalia Vargas. Over to you, Natalia.
Thank you, Tori. Hi, good afternoon, everyone. It's a pleasure to be here with all of you. Today, I hope you enjoyed the session. I will be speaking about where we are with quality improvement, and it definitely has not been a dull year in terms of quality activities. We've seen a lot of changes as a result of COVID-19 in the quality sphere, and that just continues to emphasize the importance that quality has. It has really come to the center stage of all things critical access hospital related as it relates to different areas that quality dovetails with. So based on your feedback in the past year, we pivoted the program to more explicitly make the connection between measures and improvement. And we utilized an improvement science approach, and I'll speak to a little bit more in depth about why we're using that approach. But just to remind us how far we've come, the COVID-19 pandemic really put things in a different light for us and allowed us to slow down and creatively problem solve around the issues that we've been hearing from states for a long time. For example, with the low volume measures and relevance of measures, we started to think about what really matters in terms of the program, and we've done some changes in that regard. We started with suspending the MB-QIP eligibility requirements, which I think has helped a lot of your hospitals as they dealt with the pandemic. We also worked with each of you to address hospital capacity to report on the quality measures, understanding that there were different levels of capacity across the country. And then we revisited the feedback that you gave us to address areas for program improvement as it relates to the quality measures that are relevant to critical access hospitals. So this really put you at the center, and we appreciate you as being our key partner in this quality improvement work. And if you go to the next slide, Tori, for me. So I just want to speak to what we are doing at the moment. which is really a journey, it's not a destination. We have really, in the past year, taken the time to step back and be thoughtful about the approach. And so really that brings me to put my scientist hat on and really think about what is that foundation that can get us through that journey together in a way that is relevant for most of you. And that has really been centered around the science of improvement. The science of improvement is focused on the journey, actually, and the learning along the way. So this is why this approach has been a fantastic tool to utilize in order to look at the program differently. So the science of improvement really has a few principles, around 6 principles that centered on the practicality of the work. So without you knowing, we've been kind of all together working towards that framework and building that framework together for the program. So one of those principles has been, how do we problem solve, and making that very user-centered, which means very hospital-oriented. What are the needs of your hospitals? We've also looked at the other principle, variation in performance, that is really the core problem to address. So looking again at the issue that is not really what works, but rather what works and for whom and under what set of conditions. And so the next principle that we have explored together is seeing the system that produces the current outcomes. And it's hard to improve what you don't fully understand. So we as a team are pushing you to really understand what are those issues and how your local conditions at each of your states help shape the work processes that make the work relevant. And the 4th principle is we can't really improve at scale what we can measure. So understanding really the relevance of measures is really what it's all about. And embedding measures of key outcomes and processes to track if changes are actually causing improvements. It's really at the core of the FlexQI project that you will be implementing in the following year. And then anchoring practice improvement in a very disciplined kind of inquiry. So really being disciplined about engaging your hospitals in rapid cycles of plan, do, study, act to learn fast, fail fast, and improve quickly. Then lastly, accelerate improvements through network communities. So it's really about embracing the wisdom of the crowd. And that is really at the core, again, of what we're trying to do with the FlexQI project this year, in helping you see each other as your own community of practice. So if you go to the next slide, Tori, it will really speak to, again, bringing us back to the glue of the program, which is, in Flex as a whole, the glue has been quality, because in some ways this journey has multiple paths, but all kind of lead to quality. And if we can really understand that and grasp the importance of that, then we see that in other areas, such as the EMS area, those improvement processes are impacted by quality of care. The same thing with hospital financial outcomes. And I pulled some articles here. If you're interested in those references, please write me an email. And the same with population health. We are definitely at a right time for innovation in terms of thinking about population health, patient outcomes, and how that can really transform quality measurement in rural areas. And then, of course, the new initiatives in population health that dovetail with quality. So up next, my colleagues will be discussing in more detail some of the highlights of the year as it relates to all of these areas of Flex that, again, you will see those connections back to quality in the examples that they provide. So up next, we have the next PO, Natalia will be introducing some of those highlights for the rural emergency medical services component. Talia?
Thanks, Natalia. So hi, everybody. My name is Talia Chappell. I am one of the POs for the FLEX program, and I have a focus on EMS activities. I'm going to share some highlights, like Natalia said, from the EMS FLEX program activities and from the EMS supplement projects. We have a number of states that are working on EMS needs assessments right now, which is great to see. And I'm sure that in the coming years, that this is going to turn into some really interesting highlights for future meetings. This year, for the EMS FLEX program activities, I'd like to share highlights from South Dakota and Michigan. In South Dakota, they are providing webinars on trauma care to help improve some of their measures. In Michigan, they're hosting EMS leadership academies with 15 different rural EMS leaders after conducting the attributes of successful rural EMS agencies assessments. Now moving on to the supplement projects. Just for your reference, I've added in here in bold what the project is working towards, but I'm just going to highlight, focus on the highlight sections for now. So Arizona has launched their telemedicine pilot, and they are on track with both participating fire-based EMS services. Ohio now has 3 community paramedicine sites that are seeing patients, and so far one of them has been able to help their partnering hospital decrease their readmission rates by 3%. Next slide, please, Tori. So in South Carolina, they have 5 EMS agencies that are working to develop a community paramedicine model to serve 6 different counties that do not currently have hospitals. In Washington, the enrolled agencies that Washington is working with, they're getting to know each other a lot better. They're feeling less alone, less secluded, and they're learning that many of them have quite similar challenges that they're addressing so that they can work together on those. Florida, they've started an online and on-demand quality improvement education for their 30 newly developed rural EMS measures, which are currently still being developed. Then next slide, please. In Kentucky, they've used carryover funds for to further their goal by providing mini grants, we're calling them mini grants, to additional CPR and AED trainings, as well as training equipment. So this was something extra that they were able to figure out how to do with some carryover funds, which was really interesting. And last, but let's see, North Dakota has identified 5 focus areas that include 18 new EMS measures that they're testing. So we're looking forward to hearing from North Dakota about how their testing is going as the year continues and next year. And then last but not least, we have New Mexico, who of the 40 EMS agencies that they're currently evaluating in their project, 28% were not entering required data elements at the beginning of their project year. That percentage dropped to 10% based on educational and training efforts that the New Mexico team used. So next slide, please. I have one last slide to share with you on the FY22 EMS supplement NOFO planning. For those of you who may not be familiar with this, the FY22 EMS quality improvement projects will focus on increasing accurate EMS reporting and using the data to drive quality improvement efforts at the agency level. All state FLEX programs are eligible to apply for this funding. We estimate the NOFO to be released in December of this year, and the funding will cover 2 years, and we are anticipating providing 6 awards at $300,000 per year per awardee. So lots of great work going on related to EMS, and we're happy to see projects moving forward. If you have any questions, please feel free to contact me, and I'll be happy to answer your question or connect you with someone who can. And now I'm going to turn things over to Laura to talk about financial and operational improvement.
Hi, everyone. My name is Laura Seifert, and I'm also one of the project officers for the FLEX program. I think it is quite special that today is the day we're starting our reverse site visit, because today is my 1-year anniversary exactly of being with the FLEX program. So we've had a lot of good work that's gone on this past year, as everyone has already shown you. We're going to do a little bit of highlights, but I wanted to talk about the financial and operational improvement area kind of in general as a whole, and let you know that we're really working on focusing on value-based care and hospital leadership education, because I think everyone knows that we cannot talk about those two things separately. We have to talk about them together. We cannot have value-based care if we do not have buy-in from our hospital leadership. So in this past year, as I've been working on things, and we're really working on taking the FLEX program and focusing on improving it in the long term, the two things I really wanted to highlight were just how much of a strong interconnected network that we have, not just within our states among the FLEX programs, but also with our TA partners and our evaluation partners. In highlighting a couple of states right there, Idaho and Pennsylvania, that are really working in some value-based care areas. It also shows the interconnectedness of the entire FLEX program. I think, as Natalia mentioned, we can't talk about value-based care and improving payment and finances if we don't improve quality. And we also don't improve population health and care coordination and improve access to EMS services. So everything is very interconnected, and improving one will improve all. And that's what we're hoping to go for. And I'll just highlight a couple of quick things here in Idaho. I know that they've got contractors that are working on doing community snapshots to really find out what the communities need and where to put those resources. And they're working on a white paper right now with best practices and strategies to implement value-based care. But the fun part of this, when I started talking to Idaho of what they were doing, is that in implementing all of these things, they had reached out and spoken with Pennsylvania regarding their rural health model. And I know we've all heard a lot of good things about what they're doing in Pennsylvania. But they had also reached out, not just through the SOAR or through the FLEX program, but through the SOAR program, and talked to Maryland as well for their global budgeting. So there's a lot of great resources that are out there. And also, next up, I want to highlight and shout out our other partners, because we do have some resources that are coming soon in these areas. Being unveiled this week is an update to the Small Rural Hospital Blueprint for Performance Excellence. Back in April of this year, we had a great meeting with TASC and several of the really big names and important people that know what's going on and have a lot of experience in value-based care and how we can make it better for the FLEX program. So we've updated that draft from 2013, and it's going to be released this week here at this session, or this reverse site visit, sorry. And in just about a month or so, there's going to be a TASC 90 in August working on hospital leadership. So the TASC program has been great in helping me and all of us learn where we can go with our new resources. And on top of that, the FLEX monitoring team is also doing a project this year. They're really looking at what are the characteristics of these critical access hospitals that are already working in value-based care. If we can kind of learn those characteristics of where everyone's already doing it, let's see if we can't spread it and make it work further along the line. And now that's it for me. So I'll toss it back to you, Tori.
Thanks so much, Laura. And thank you so much to my entire FLEX Project Officer team. I'm so lucky to work with these wonderful people. So just to cover some population health and innovative model development highlights from the FLEX program, we will be continuously focusing on the Healthy Rural Hometowns Initiative, which was enacted as a part of the previous administration's Rural Action Plan. So these focus on the 5 leading causes of death. We are also looking to restructure the population health toolkit to be more focused in on the 5 leading causes of death and what your FLEX program can do to address those. We will also be launching an expansion on our previous work for the chronic obstructive pulmonary disease, or COPD work that we started a few years ago. So be on the lookout for some information on that future project. For innovation, I wanted to highlight the CMS chart models, the community transformation track, CMS anticipates to be announcing those selected lead organizations in fall of this year. And the AOC transformation track will be now delayed for a release in spring of 2022. So still more time for your hospitals to consider participating in that accountable care organization transformation track through CMS. We will, of course, keep you updated from the FORHP level, and please make sure you are registered for our weekly announcements, which will highlight important updates on these issues. So just to highlight some fabulous work going on around the country that is funded through the FLEX program, in Washington State, they annually fund population health subrecipient programs with their critical access hospitals and communities. Some of the highlights from the previous year have been work on diabetes prevention, nutrition, dealing with loneliness and isolation. So some great work going on in Washington. In Georgia, they are funding mental health first aid trainings. In Arkansas, they have a renewed interest in utilizing community health workers to do health promotion activities in their rural communities. Minnesota is doing a very cool innovation, partnering with a private insurance company to provide training simulations for obstetric care in their critical access hospitals. And North Dakota is focusing on emergency department consumer assessment for healthcare providers systems, or EDCAPS for short, on focusing on their patient engagement in their emergency departments. I encourage you all to reach out to your fellow FLEX programs to find out more information, but these were some that myself and the 4 project officer team found to be extremely innovative. So where are we going? My colleagues mentioned a number of things, and I just want to throw them out as highlights to you. In FLEX Program Year 3, which starts on September 1st, we will be engaging in the Quality Improvement Project. These will include the Quality Improvement Labs, which you'll hear more about in later today's session. We really consider this a pilot and a learning ground for new ideas. So we may expand it in future years to other FLEX program areas, such as financial and operational improvements. Talia mentioned the EMS supplement for FY 2022. Please be on the lookout for that notice of funding opportunity in December. We will continue to keep you updated as we find out more information on the contents of that NOFO. Laura mentioned the focus on hospital leadership and value-based care. And I mentioned the leading causes of death. That will be a focus area for our population health efforts. As a team, we will also attempt to develop more templates for you all to ease reporting requirements and make it very clear how you can report back information to FORHP. As a reminder, this is how we split up the country in the project officer assignments. You have our email addresses here and our lead areas should you have any information, need any information. Here's our contact information. We are always available to you. You are our partners, and we appreciate you so much. We look forward to having the rest of these 3 afternoons with you and learning from you all as you share your best practices in the various breakout sessions. All right, I'll turn it back over to you, Tracy. Thanks so much. We look forward to having a great week with you.
Thank you so much to our excellent group of federal project officers. We really appreciate it. So as we're getting ready to start our opening keynote session, we're really excited about sharing this content with you today. I wanted to share a little bit about where you can submit your Q&A questions if you do happen to have them. So on the right side of your screen, you should see a little button in the corner that says Q&A. So if you click on that, that's where you will have the opportunity during these plenary or keynote sessions to submit a question or ask for clarification. And our team at TASN is kind of moderating and seeing those to be able to field those questions and be able to assist in moving those over to the speakers as we can. So please don't hesitate to send along any questions that you have. All right, so I'm going to start introducing to you our next keynote session, or our opening keynote session, as we get the content ready for that speaker. But our opening keynote session is about health equity, and the title of it today is Left In or Roped Out, A Rural America's Journey Toward Health Equity, and it will be shared to you today by Benjamin Anderson. So a little bit first about what this session is. We're hoping that at the conclusion of this session, you, the participants, will be able to communicate the definitions of health equity in the context of rural and frontier healthcare delivery. that you'll be able to describe the structural contributors to the geographic health disparities that exist between rural and urban, that you can apply tools for measuring health disparities in your own organizations and communities, and that you can initiate system transformation efforts that address disparities leading to health equity between rural and urban communities. So with that, our keynote speaker today is Benjamin Anderson. Benjamin's the Vice President of Rural Health and Hospitals for the Colorado Hospital Association. There, he provides leadership and direction in the development and execution of the association's rural strategies, advocates on behalf of the rural hospitals and health systems in the state, and works to develop strategic partnerships with organizations that affect the health of rural Coloradans. Benjamin has 20 years of experience in healthcare and nonprofit administration, and is a nationally recognized leader in health equity and transforming rural healthcare through an innovative approach to attracting physicians to diverse, underserved areas with a generous paid time off package to be used for international volunteer work. Prior to joining the Colorado Hospital Association, Benjamin spent 6 years serving as the CEO of Kearney County Hospital in Lakin, Kansas. Benjamin has a Bachelor's of Arts degree in English and an MBA from Drury University, as well as a Master's of Healthcare Delivery Science from Dartmouth College. Thank you so much, Benjamin, for being here with us today.
Thank you for that warm introduction, Tracy. I assume you can all hear me. Just by a show of hands, we're in good shape. I'm going to jump right in to telling you some stories. And the first one is about my life and my family's life in COVID-19. So this is a picture of our two daughters. At the time they were 7 and 5, now they're 8 and 6. But at the time, this was March of 2020, and this was day 10 out of 14 where they hadn't left our house. And this is a makeshift carriage with a blanket or two, and it's being pulled by Stinky Pinky the pig. And they are about to start climbing the walls these days. And I was working 18-hour days for the Hospital Association, trying to do my part to keep rural hospitals open in Colorado, and nobody knew about this mysterious disease, at least what we know now. And so this looks fun, but we were climbing the walls, and somebody was going to get hurt at our house. And so we recognized on day 10 that we really needed to be in the country. And so my wife is from a town of 2,000 or 2,200 people in Northeast Kansas, and this is the picture off the front porch of her parents' house. And so we recognized that if we could hunker down for 2 weeks, we would be able to get there and touch anything, because our kids weren't allowed to touch a thing. And what I didn't share with you is that those little girls that were 7 and 5 had twin brothers, both of them. So there were two 7s, 2 5s, boy-girl sets, and so all 4 of them needed to get out and touch stuff. And so we did. We hunkered down for 2 weeks, and we finally, bathroomed on the side of the road, and we made it out to Northeast Kansas. And I'll never forget getting out of the car and realizing that they had isolated, we had isolated, we could touch anything we wanted to. I want to share something that happened when we got there. These are our 2 girls, and these pictures were taken on the farm. And as I was working 18-hour days out of a guest bedroom, I was looking out the window and I was watching them experience rural life for the first time, really in an extended way. And I started seeing them as I was watching them climb on the cattle guard and play down by a little creek and a pond that's on that property, and ride their bikes and climb on the gravel and help out in their oma or their grandmother's garden. Doing dinner around the table, doing evening devotions as they did, morning chores, all of that. I was able to see rural life through the lens of a little girl that was my wife, who was their same age. And on the same piece of ground, imagine what life would have been like, because I grew up on the West Coast. I grew up in an urban area, and I married into a rural family. And I was able to see what that looked like and imagine her life, and how sacred it was to her, see how sacred it was to her. And then I was able to imagine her mother on that same piece of ground, growing up not even a mile or 2 away from there, and also her mother, because there were 5 or 6 generations back when her family settled this land. And so I was able to see their life, and as I was as I was watching our daughters run through a windbreak, which if you all aren't from the plains, a windbreak is a group of, it's a row of trees that blocks your house from the grueling wind in the plains. I was able to watch our daughters run through the windbreak, and the words, "Oh, beautiful for spacious skies, for amber waves of grain, for purple mountain majesties above the fruited plain. America, America, God shed his grace on thee and crowned thy good with brotherhood from sea to shining sea." Elizabeth Ann Bates was a poet in the late 1800s that wrote those words in a poem that later became the patriotic song, America the Beautiful. She wrote them about the identity of America immediately after touring rural America on a train. She saw rural America and came up with those poetic words way before her time. And I thought, as those words came to my mind and as I watched our daughters play, this is what we're fighting for. This is what we're fighting for. This is the life that we want to preserve for our children and our grandchildren, because we want them to experience a culture where people are honest as the day is long and make decisions with their kids, and their grandkids have to share their last name, and do the right thing by people and work hard and deflect attention and are humble and reliable. All of those things we wanted. But I also want to acknowledge in that same lens that rural America has a shadow too. That not all of rural America is the picturesque rural America that perhaps my wife remembers growing up with. That we've got some deep-seated issues in rural America too. We've got racism, we've got bigotry, we've got fatalism, we've got deep health disparities, we've got chronic problems within communities, social isolation, depression, extremely high and climbing suicide rates. We've got major issues going on in rural America too. And if we want the life for our children that we envision, that my wife grew up with, we've got to address those shadows. And that's going to be much of what we talk about in this talk about left out or roped in and our journey toward equity. This is a tool. I was spent, as Tracy mentioned, I spent years as a scrappy rural hospital CEO on the Kansas-Colorado border, and that's where Tracy and I got to know each other. And this is a tool that we would use where I was, and at the top of this, we would call it an outcomes pyramid. And at the top would be any outcome. It could be COVID. It could be anything. But we would pick a health outcome or a series of health outcomes. And that would go at the top of this pyramid. In the middle would be the decisions that lead to health outcomes. We would call those the actual causes or the human behaviors. And those things were directly what were driving the outcomes. And that involves both individual accountability and policy drove those as well. But then at the bottom of the pyramid were root causes or the human condition. And we would also call those the social determinants of health. And so we would use this as a strategic tool when I was a CEO, and we would get our hospital board and our school board and our community and our sheriff's department together once a year, and we would sit them in a room and we would each have them complete one of these pyramids. But we would start by saying, so what kind of shape are our kids in? Do their teeth hurt? Are they hungry? Are they overweight? Do they have enough food? Can they focus? Are they being abused? What's going on with our children? And we would get down to, as each of us completed one of these pyramids for our own sectors, we would get down to that bottom human condition, because if you line these pyramids up next to each other, the outcomes may be different and the human behaviors may be different that lead to those outcomes. But at the bottom, the human condition was almost always the same. And we would all agree as a group, we're going to focus on this one thing that we think we're going to put all of our resources into, that one or these two things that are going to improve all of our outcomes simultaneously. What we figured out was that we had an issue with food. But I want to stop, just pause for a moment and just acknowledge you can't solve structural problems with individual solutions. So let's go back to this for a moment. We can't solve the problems on the bottom by simply trying to address human behaviors. We can't do that. The two are different, and we need to understand the difference between Both. So important. And this piece of art was put together by Andrea Roche at the University of Texas, San Antonio. Does brilliant work, but I just thought it was so applicable in this case. So what did we do in our rural Kansas community? We launched a survey in our town. And again, we were the 10th most remote town in the United States, according to the Washington Post. It was not a contest we knew we were in, and we sure weren't trying to win that contest, but it was what it was. And so we recognized we had about 2,200 people in our town of Lakin. There were about 800 or 900 in the town of Deerfield. And we needed to get most or all of those folks, as far as households, to complete this. And so we ended up with an 85% household response rate in this survey. And essentially we asked we got all the demographic stuff out of the way, age and gender and socioeconomic status, insurance type. Then we asked how they define their health and wellness from several commonly accepted terms. And then we asked who they believed was responsible. Was it their own choices? Was it the environment? Was it the health system? Who's responsible for helping improve their health and wellness? And then after that, we asked in the major sectors of society, healthcare, public health, early childhood development, research and extension, faith communities, the employers, community as a whole, with lists of services in each of those sectors, what were people aware of that would help them improve their health as they define it, and what would they want to see more of? And we got an 85% response rate. And I just want to pause and say this is where rural shines, that we know each other. And we engage people that Malcolm Gladwell in his book, The Tipping Point, called connectors. They're the Paul Reveres. There's a reason Paul Revere was so effective going down his famous ride is because everybody knew Paul. We found the Paul Reveres in our community. We convinced them of the importance of it, and then we went from there. So I want to share a little window into the disparities that existed in our community. So here's what we found. Just in the healthcare sector alone, in every single subcategory in healthcare, when we divided the answers by people group, white people were more aware of services than Hispanic people. Again, we had 60% white folks in our county, 40% Hispanic folks. In every single case, white folks were more aware of services than Hispanic people. In all but 3 cases, Hispanic or Latinx people were desiring more services than white folks were. The lesson we learned through this is, if a service is not available in a language someone understands, at a price they can afford, at a time they can access it, at a location they can get to, in a way that they can understand it, it might as well not exist, or worse. This drinking fountain ain't for you. We were a fast-growing hospital, growing very quickly, and believing that we were an equitable organization because we were providing the same care to everyone. But the reality was that actually that's not for providing the same care to everyone during our banker's hours from 9 to 5. If you have this insurance type or that insurance type, actually doesn't drive equity. And we had some learning we had to do. So for rural Americans, here's some lessons learned. To truly thrive, we as leaders must begin by asking hard and insightful questions. We got to begin by taking what we're already measuring and dividing that by people group to discover the disparities we don't think are there. And we have to have the courage and fortitude to lead efforts to address those disparities. It's not good enough to simply identify them. We have to say, are we okay with this? And invariably, we must conclude, no, we are not okay with it. Add in COVID. COVID revealed the fault lines that were already existing in our healthcare delivery systems. I mentioned some of them, but workforce, the status of our workforce, poverty, access to resources, access to healthcare, racial or other inequities in our community that were already there, but COVID made it impossible to ignore these things. So when we think about strategy, we got to start at the end in mind. This is a teacher of mine in grad school taught me this. We start with the end in mind and we work backwards. So it requires reverse thinking. So we have to start by saying, what's the ultimate outcome we're after? And then what do we have to do to get that? And then what has to happen for that to happen? What has to happen for that to happen? On and on. And so what we did in Colorado at a statewide level, when I joined the association 2 years ago, was we built out what's called a driver diagram, or we built out a strategy started with the end in mind, and the end in mind was achieving optimal health for rural Coloradans. But we knew that requires monitoring outcomes of deliberate and tactical interventions fueled by training and partnerships to achieve SMART goals, specific, measurable, attainable, relevant, time-sensitive goals based on careful assessments of reliable information. That was the driver diagram that really drove the strategy we developed. And I can summarize it in a different way through 4 buckets. We developed a vision, which is value-driven systems, increased capacity, and innovative payment structures that optimize health and strengthen rural communities. That was the North Star. We were after that, optimizing health for rural communities. And we put them in 4 buckets: leveraging data to inform system development and interventions, increasing leadership and workforce capacity, improving access to excellent and holistic care, and strengthening partnerships and collaborations. We had sub-bullets, sub-projects under each of these buckets, or each of these focus areas or strategic priority areas, and we dove in. That strategy was really built around 80% capacity building and 20% policy. 80% capacity building and 20% policy. Traditionally, we're an advocacy organization. We know how to kill stuff in the legislature, right? We knew how to do that. We know how to pass stuff in the legislature, but we recognized that we didn't have the capacity to make good use of health policy, good policy, if we didn't have the leadership behind it. So we had to focus on building transformational leadership and governance within our healthcare delivery systems. That became the cornerstone of this strategy. And with that, and enter COVID, we figured out that every bit of that strategy was not only still relevant in COVID, but it became more relevant. And funders opened up their purses to see that we could get it done. So we were able to accelerate the impact of that statewide strategy when we really got organized and collaborative. So we went from there. We got a pretty substantial 6-figure grant to produce a playbook that went live in December of 2020. And if you haven't seen it, you can find it. There's a link here on the set of slides that you can have, or you can just dial in rural COVID playbook in Colorado, and you'll find it. It's a free resource. It's online. But a research partner of mine and I and several other writers got together and spent 6 intensive months on site in the middle of a pandemic, interviewing hospital CEOs and board members and rural clinicians and public health directors and patients, asking them what they were facing and what they would need. And what we came up with, something was akin to Patrick Lencioni's book, 5 Dysfunctions of a Team, that's built around parables that pull rural leaders into the story, into the challenges. And we identified 9 common challenges. We call them the 4 C's and the 5 S's, and they're clinical care, communication, community, cross-system collaboration, space, spending, staffing, statistics, and surveillance, and supplies. You can get on, and rather than being a simple website that says, here's where you find PPE that could be outdated in 10 days, this is really a capacity building tool that teaches folks through strategic prompts how to solve their own problems. So we've gone beyond that, and now partnering with a Harvard case writer named Dr. Aaron Sullivan to write and produce cases that we're teaching now across the country, but starting in Colorado. And some of the examples are in crisis communications, leadership and equity, physician burnout, or staffing. And we're writing these 8 or 10 page cases written at a 10th grade level that a rural farmer board member can read, identify with, and jump into. And we're using them to equip people to solve their own problems. And so we're rolling these out now in North Dakota and in Utah and Colorado and elsewhere. So this is sort of phase 2 of that statewide strategy. So I'm going to transition now in the last half of our talk to talk really through, so if that's how we're addressing equity at a statewide level, right, with perhaps through the lens of the National Rural Health Resource Center, right? How they would think about strategy at a state or a national level. We're going to transition this now to a local level. And I know many of you manage flex funds from around the country. And so I'm giving you a little window into what a rural healthcare delivery system may be dealing with or addressing disparities or issues within their own system. And this will use the playbook challenge area, clinical care. Tell you a quick story. This story is about a man named Don. I was a rural hospital CEO with an attached nursing home, and I got a call from the director of nursing saying that this man was using racial slurs. Won't repeat many of them, but using racial slurs and really offensive language related to gender and other things with some of the staff. 40% of our staff mirroring our community were Hispanic, and there was some language that was coming in that was not helpful. And he was not ambulatory. They said they could not evict him, and they wanted me to come visit with him to figure out what to do with this guy. So I went over and sat down with him in the office of our director of nursing, and I asked how he was doing, and he said, not good. And I asked why, and he said, well, you have a bunch of half-breeds working here. And I remember responding to him saying, sir, can you see how calling somebody a half-breed might be taken as offensive or disrespectful? And he said, well, what do you want me to call him? I said, well, as the father of several children who are half white, half Latino, I prefer to call them David, Naomi, and Maria. They have names. They deserve to be treated with respect. You have names. You deserve to be treated with respect. I don't want them called half-breeds any more than I want you called the old bald guy in the wheelchair. Now, as you might have gathered, I didn't handle that situation as well as I could have. I was noticeably defensive. I was frustrated with this guy. It was 2020. There's no reason we should be communicating this way. It's, we're 20 years into to a new millennium. That we're way past this. And what I recognized though pretty quickly was that I wasn't going to get anywhere with this guy like that. He left, I left. And there was no commitment for any behavior change. And so I went back into his room and said, man, I think we got off on the wrong start. I want to take you out for a steak dinner. And you got to understand that an offer for a steak in our rural context, this picture was taken 20 miles east of our house. And the ultimate expression of love is an oversized, partially cooked piece of red meat. And so here I was offering my very best to him in a local cultural context. And he responded by scowling at me and saying, ain't got no damn teeth. What the hell am I supposed to do with a steak? I realized I swung and missed on a steak. And before I offered to puree the steak or something like that, I said, all right, man, how about a beer? And he paused and he looked left and he looked right and he said, now that I'll do. I said, what's your flavor? He said, Bud. I said, Bud Light? He said, Bud Heavy. I'm like, man, that's like drinking a steak. You're serious about it. All right. So I went down, risked my reputation, went down to the local liquor store, and I bought a 6-pack of Budweiser bottles, and I walked them in double-fisted into that nursing home at 5:30. So it was technically after hours, 5:30, and I went down and sat down and started drinking a beer with this guy. And I learned his story through that process. And I learned that he had grown up in unthinkable circumstances, had no family connected to him, had maintained or been able to maintain no meaningful relationship through the course of his life, that he was living before he came to the nursing home in an unfinished attic of someone's home without proper sewage or heating or electricity or temperature controlled environment, and that he was not ambulatory and somebody was charging him rent out of his Social Security for that. He came into the hospital and he was told he couldn't leave because it wasn't safe to go back. He was angry, frustrated at the idea of losing his independence, and he actually had fired America's favorite doctor with a series of expletives that started with the letter F. And I learned that he regretted that. And so I'd asked him initially, hey, what do you think about apologizing to that doctor? He really is a sweet man. And I could tell it just wasn't something computing there. So I let it go. But then I was speaking at the Becker's Hospital Conference in Chicago, and I got this text while I was on stage, and it was this picture of flowers. And this guy, Don, had spent half of his Medicaid allowance on flowers for the nurses, for the nursing staff. And it said, to everybody except this one nurse. Thank you so much. And so I went back and over another beer, I said, thanks for the flowers for everybody. Did you have to leave the one out, right? And he smirked, didn't say a thing. And then a month later, another bouquet just like this came to the nurses, and it didn't exclude anyone. Something was happening in Don that was also happening in me. And I went back to the idea of apologizing to that doctor. And I said, man, you don't have to say it to him. You could just write it down. He said, man, about that, they pulled me out of school in the 3rd grade, and I don't read so good. And it hit me that this man's illiterate, that he spent his entire life not being able to read a street sign or a book or a magazine or an idea. And it was no wonder he was bitter when he was watching a woman with brown skin, passing him by on her way to college as she wiped his bottom. And it did not excuse his very damaging and deplorable behavior, but I was able to see into his life and empathize with him. And so I said, man, what if I just write it down and you tell me what to write? And he agreed. And so he said, Dr. Miller, you're the best doctor I've ever had. I'm very sorry for the way I mistreated you. The hell I put you through. You sure didn't deserve it. I don't know where I'd be if it wasn't for you. Probably stuck in the VA somewhere. I hope you'll forgive me. Sincerely. And he signed his own name, Don George. And he died a couple weeks later in his bed. But this man died knowing what it meant to love and to be loved and to forgive and to be forgiven. And I have learned so much from him, and I have the permission from his power of attorney to share this story, which has been so impactful to me. But what happened when I spent so many days over at the nursing home was that we began to unlock a deeper, darker issue in the nursing home. Don was not demented, but many of our residents had dementia and perhaps of the Alzheimer's type. And what we learned was that we were drugging through chemical restraints, drugging these people to address their behaviors. We didn't have enough of a diagnosis with Don to do that, but others we had, and what we were doing is essentially putting them to sleep until they drooled themselves to death. And so we recognized that we had this major problem, that we were second highest in the state in the use of chemical restraints. We had a serious problem, and my mind went back to a lesson that a mentor taught me, that any instance where persons avoidably harmed due to broken processes or even good ones that could be better, we've committed a moral failure, that these people, our most vulnerable folks, their lives are in our hands and we had to act now. So here's what we did, sort of as we wrap up. Here's what we did to address it. We implemented a 6-question tool. First, what outcome needs improvement? We needed to reduce the use of chemical restraints in our skilled nursing facility. We thought about the key stakeholders. Who were the stakeholders that could help and contribute? We'd care about this. We developed a list. Then we asked, where are there opportunities to contribute? Then we looked at each of those folks and we thought, what could they contribute to something of the greater good? We asked, why isn't it already happening? Perhaps the most important question. We're ignoring the data. It's hard. It's uncomfortable. We hadn't prioritized the necessary changes. Then we asked, how do we measure its success? Well, simple. The number of folks using those psychotropic meds over the total number of folks. Like we could get it down. And we wanted a 75% reduction in a year, knowing that wasn't easy. We did that. And I'll give you just a quick couple of examples. The woman that was agitated after dinner every night because it was time to do the dishes, we just took her in and let her wash a pot or two. And then she didn't need the meds anymore. For the one that wanted to get out and to go home, well, we took her out for a walk every day. And at the end of a lap around the building or two, she was ready to go in and go to bed. She didn't need the chemical restraints. Over and over, we learned this hand-in-hand training, and we saw 38% drop to 8% of our residents on these psychotropic meds. We saw staff that were frustrated and quitting to becoming equipped and empowered. We saw family and friends that were complaining and concerned to becoming more re-engaged with their families. We saw skin breakdowns to decrease. We saw staff morale increase. And I go back to this image or picture of the movie Awakenings. It came out in 1990. Gosh, it's a 30-year-old movie. And it was about this doctor that discovered a miracle drug that caused people that have been sleeping for decades to wake up and experience life. And it's a true story based in the 1960s. And it was with Robert Williams and Robert De Niro. But I think of this and I want to weep as I think of what was happening in our nursing home, because we weren't willing to do the hard stuff and to look at things and take the data and look at the data and figure out where the disparities were between us and between others, and look at the structural issues that were driving them. So I want to close just with this. This stuff is workable. It's workable. It can happen. And this is the 6-question tool we use. What are the outcome needs improvement? Who are the stakeholders? Where are there opportunities to share? Why is it already happening? How do we measure its success? When do we expect to see progress? This tool is applicable across industries, across states, across organizations. And we take what we're already measuring and we divide that by people group. It really is that simple. And it goes beyond race. Equity goes beyond race. It's so important that we look at race. But that's not the only form of disparity in the United States and in our industry. So finally, to close, when I resigned my position as hospital CEO at Kearney County Hospital to move to Denver, I had a kid with special needs. We had 4 of our kids were there. One of them had some serious educational issues that we couldn't address in a rural community. And so when I resigned, she said, Benjamin, I accept your decision to resign or to move to Denver. But please know that there are 60 million of us who can't just move. We're still here. And this woman was the mother of 2 adult children with special needs. She had all the credibility to say that. She was on the governor's task force for adults with special needs. She knew the pain of living out there. And she said, please remember that we're still here. This is our home. This is our identity. These people make do. And so I want to close by saying this. I know that you who are managing these flex grants, you get this. And you are a voice for some of the most voiceless people in the United States. If you haven't felt seen in a while, know that you're seen today. And that your work is making a difference, even if you're calling folks trying to help out and they think you're a surveyor, and so they're hanging up on you because they don't know what branch of government you're from. You are making a difference. You are living out this gal's call to action. I'm grateful to be with you. I look forward to connecting with you either on LinkedIn or in an email. Tracy, feel free to share my email. I'd take emails from any of you, but thank you so much for the opportunity to spend this time with you.
Great, thank you so much, Benjamin. It's always, exciting to hear you talk. And what I really liked about your presentation today, and we'll get to some questions. So actually, as I kind of tell about a couple of my takeaways, a reminder that on your screen on the right side, there is a Q&A button that you can click on, submit a question. Our task team will pick it up and we'll make sure to address it here with Benjamin in the few minutes that we have. But what I like about your presentation and your sharing about the stories about the pandemic and health equity and the playbook too, is that you're right, the work to address health equity and any inequities and as well as the pandemic, it's hard and it's certainly uncomfortable. It takes us all out of our comfort zones because we all have a very unique perspective. Even the people that I share my house here with, we all have different perspectives, even though we see each other now every day. But we bring something different to the table all the time. And I think what you shared as well about really digging into the issues and asking why and valuing each other's perspectives and then really thinking holistically and strategically about approaches is crucial. And I think that nothing I can imagine in the last 10 years or so of my employment in this work in rural healthcare has brought forward more the concept of leading not only with your head but with your heart, as health equity and the pandemic have done. So thank you for sharing your thoughts today and recognizing the hard work that all of the participants here are putting into their programs in the States, because it truly is, it's sometimes pushing a boulder up a very, very big mountain. A couple of questions that did come in was that related to the playbook that you shared was, first of all, if there's a link to that report. So I'll address that here quick. In the attendee hub, there is a downloads section, or I think there's a more section, and within there you can find a link that we've already kind of pre-populated with that playbook. But we'll be sure to send that out as well. You can also access it on the TASC website by just searching for the COVID playbook. It's there as well. And in terms of, somebody also was asking about the slides being available, so we'll get those from you, Benjamin, and they'll be on the TASC website come next week, and they'll also be linked here in the attendee hub. But a question for you, Benjamin, is that under the World Strategic Priority Plan, how much change do you see in the areas that were measured?
Sorry, I had a volume issue. What was the question one more time, Tracy?
Yeah, it was under that Rural Strategic Priority Plan, how much change did you see in the areas that were measured? I know that just came out in 2020 and late December, but what have you seen so far?
Yeah, I could share another slide if you wanted me to, or I can just answer the question. So really remarkable. So under data, we developed a dashboard in Colorado using what's called ODIN, or On-Demand Hospital Information Network, that allowed us to allows our rural hospitals and providers to use claims-based data to analyze where care is going, what care is coming, what care is going, what care is staying, and to use that to make strategic decisions. So that was rolled out at no cost to any of our rural hospitals. It's been really helpful, and we've seen some other states come alongside and tap into that data as well in their own states. But it's statutory-based, claims-based data. So that was one big win in the data area. With regard to the playbook, we included in that a capacity assessment that's 8 or 9 pages. We're having all of the hospitals on the Eastern Plains of Colorado complete that capacity assessment by September of this year. And we're producing a white paper that's essentially going to tell folks like the NRHRC, like the AHA, like the NRHA, here's a window into what's going on in rural healthcare delivery, and it's through a health equity lens. So we've got that coming. We formed, with regard to leadership development, we formed partnerships with Dartmouth College and the University of Texas to get scholarships to 2 elite master's programs, the Master of Healthcare Delivery Science program and the Master of Science and Healthcare Transformation program. They're offering rural scholarships to get rural leaders into those programs, and we're formed a cohort between Texas and Dartmouth where they're taking their action learning projects and they're sharing them with each other. And so we're into our second class of those folks right now. The first class just finished in June. Second one starts this next month. And we're building out a cohort of transformational leaders there because these elite programs really do value rural leaders. So that's another piece. And then we've started building out a case library, as I mentioned earlier, of these cases that are great to engage rural board members. And so we've started engaging rural board members and CEOs and introducing these cases in individual hospital board meetings, but also at a virtual level, bringing folks in to help them learn to solve problems. We launched a collaborative initiative with Angel Flight West, which is a network of several thousand volunteer pilots that use their plane, their gas, and their time normally to fly patients. But during COVID, we engaged them to fly 500,000 pieces of PPE all over rural Colorado, which solidified a relationship with Angel Flight West. And we are now in the process of engaging them to send specialists on free airplanes out to rural communities, which makes specialty access affordable. Where normally you'd have to, have a pretty high priced surgery specialty to sustain something like that. So that also happened. And then we've been able to engage foundations to fund a lot of the rural research work that wouldn't have otherwise been fundable, because when COVID happened, they opened up their coffers. I could get into more detail, but I want to respect your time also, Tracy.
Yeah, that's a great response. It's interesting that such a broad scope of impact in the things that have happened already too. I was looking actually at that degree program. When I saw your bio and I was reading it to prepare, I was looking at your credentials and was looking up that master's program, and that's a 1-year program, isn't it? Kind of a quick rapid course.
Yeah, it's a 1-year virtual program. You can type in Google Master of Science in Healthcare Transformation at Texas, or Master of Healthcare Delivery Science at Dartmouth. They're both 1-year virtual programs designed for 40 and 50-something leaders. They train generals. They're pass-fail. They don't have papers. They don't have long timed exams. They're meant to take folks that really don't need a master's degree, another master's degree, or whatever. They're training people, equipping them with skills to change systems, and those systems to address disparities and to change lives. So I can't believe more in them. I graduated from the Dartmouth one, but one of my favorite faculty from the Dartmouth one went to Texas. And so highly recommend both those programs if you're looking for a life-changing experience, especially to refill your tank when you're feeling pretty tuckered out after COVID. So pretty cool.
Right. Yeah, and a rural focus too with scholarship. That's awesome. One of the other questions that came in was about a slide you were sharing, and I think it was the results from your survey. And you had, when you were describing those results, had talked about how it was comparing whites to Hispanics about knowing services. And the question, the person asking the question was just wondering, why just Hispanics? What about African American and Native American individuals?
Great question. Very valid question. So I can answer that. So in our service area, we had patients from 30 countries in our service area, one of the most ethnically diverse areas of the United States. Almost all of that diversity was one county over, which was in Finney County, because the world's largest beef packing plant was there. But in Kearney County, we were essentially 60% white, 40% Hispanic, and anyone else that didn't fit into white and Hispanic made up a total of less than 1% of the remaining population. So We started by addressing the population in our own county, but we did scale that survey later on to our surrounding counties as well. And it ended up, at this point, it's been completed in 6 Kansas counties. And when we did that, we were able to look a little deeper at the ethnic diversity in our area. But we just, that was data out of our first year and only in our own county. So it represented the population that lived in Kearney County. And then we scaled it after that. So thanks for the question.
Great, excellent. And if there's any other questions, now is the time to submit it in the Q&A portion of your web player, and we'll see that and move it along.
I think if you don't have any other questions, I have a final comment.
Yeah, what's that?
I have been on the receiving end of the work at the NRHRC and specifically the flex work. And this is a group of people that is helping people help other people help other people. Largely invisible, often unappreciated, highly impactful. Highly impactful. I see you. We see you and the work you're doing. Your work matters. This work is important. There are people who will never know, whose lives will be saved, who will never know that you had a role in what happened with them. So they won't ever be able to thank you. But please know that you are making a difference that way. Keep at it. If you ever need a shot of encouragement, shoot me an email. I'll give you some specific examples about why your work matters. So thank you so much for this opportunity to spend time with you.
Thanks so much, Benjamin, for those really kind words. Everybody needs to hear that, I think, and thank you so much for taking time out of your busy day to spend time with us here today. So we do have a scheduled break now of about 30 minutes, and there are some optional networking conversations, and we really encourage you to join those, to connect with other State Flex program peers, to chat and discuss a topic. We wanted to design a way that it would be kind of like if we were together in person, you were bumping into somebody in the hallway and talking about the session that just happened, or talking about a similar project that you have with one another. And so we really wanted to provide that sort of casual networking opportunity for you. So the topics that we've kind of designed for each day will actually change today and tomorrow. And today's topics include health equity, COVID-19 and health disparities, telehealth, community paramedicine, and then an opportunity also for new Flex program staff to talk to one another. So you can access these networking rooms or the upcoming breakout sessions as well back in the attendee hub. And these specific networking conversation links, you can go by in the attendee hub, going to your upper right part of the screen and clicking on networking, and then you'll see the different topics that are assigned for today. So starting at 1:15, those virtual networking sessions by topic will open. There's somebody in the room to kind of feed some questions to the group and kind of get some introductions from, but really just a casual opportunity to connect and talk with each other. Otherwise, do feel free to take the opportunity for a break, and then we will convene with concurrent breakout sessions, again, linked back in the attendee hub that start at 1:45 Central Time. Thank you all very much.